Okay, sir. I'm presenting the case of 45-year-old male who is a resident of Sikar, Rajasthan, and a bank executive by occupation. He was admitted with the chief complaints of recurrent complaints of burning maturation since last 6 months and passing of fecal matter in urine since last 5 months. The patient was admitted all right 6 months back. He then started developing complaints of burning maturation. The patient had associated high-grade fever with chills. For the above complaints, he consulted a local practitioner and was prescribed oral medications. There was partial relief of symptoms, but the complaints returned as soon as the prescribed medications was over. The color of his urine changed about 5 months ago, as noticed by the patient. He started passing fecal matter mixed with urine. However, the patient also has an old history of constipation. There is no history of PR melina, no history of hematuria, no history of appetite, no history of joint pains. Known comorbidities, and he has no prior surgical histories. He's a vegetarian, right? Has a history of on and off constipation since last 5 years, for which he is taking over-the-counter medications. His bladder habits are normal, and there are no known addictions or allergies. There is also no significant family or drug history of the patient. In summary, it is a 45-year-old male symptoms of recurrent UTI since last 6 months, passage of fecal matter mixed with urine since last 5 months, and old history of constipation since last 5 years, which has been managed conservatively. So this is the basic history, sir.
Yeah, got that. Can you go back to the first patient slide? Based on this, what are the thoughts that are coming to your mind? You already given a provisional diagnosis, but what is the cause of that diagnosis? That is more important to decide because treatment will depend on that.
Yes,
So, what are your thoughts on
the patient has a typical history of recurrent UTI and fecal mixed urine. So it is
I'm not questioning your diagnosis of colovesical or rectovesical fistula. We accept that. But what is the cause of that? There are many causes for colovesical and colorectal fistula, rectovesical fistula. So, what are the causes of colovesical or rectovesical fistula?
So the most common cause of colovesical fistula is the complication secondary to the sigmoid diverticular disease.
Yeah, what else?
Secondly, it can be due to malignancy of the sigmoid diverticula or the bladder, or the Crohn's, and the Crohn's disease also shows some similar picture. Yes, sir.
Why do you not think it is Crohn's? What would be your thought it is Crohn's?
Sir, does not present any bowel symptoms as such, except constipation.
So is that acceptable for Crohn's, or there's something different in Crohn's?
Sir, in the case of Crohn's, the history of diarrhea is also there. There's a typical history of abdominal pain after intake of food. Bowel habits are altered. Patient has recurrent history of SII also. Disease history is also present, so he can present with other fistula diseases.
So why are you ruling out malignancy as a possible cause?
Sir, pardon?
Why are you ruling out malignancy as the possible cause?
So malignancy can be a cause. However, it's the most common cause is the diverticular disease. So it's my first
accepted. That possibility I am not questioning. What yes, I want to, why is it not based on your history? What are your thoughts about it being a malignant cause with constipation of long duration? You may have diverticular or not. Diverticular disease is diverticulosis is more common than diverticulitis. Now, yes, diverticulitis leads to colovesical or rectovesical fistula, but yes, he has no he had fever with chills and rigors, and you think that it's because of urinary tract infection. I got that, but what do you think? Yes, what do you think Crohn's will cause? He had fever. He had so diverticulitis is in. So he's had an attack of diverticulitis, which has resulted in a fistula. That's what is your thought process.
Yes,
I
sir.
get that, but why is it not malignancy?
Uh, so he has no complaint of PR bleeds as such. He has no associated weight loss histories, and
Is it
there is
present
no
in
suspicion.
100% of patients?
No, sir, it does not.
So you can still rule it in. You should keep that as a thought because the management of a malignancy is totally
Yes, sir.
different. Yeah. So
Yes,
with
sir.
this, let us go to the first slide.
Yes, sir.
His area of residence doesn't matter, but can you go to the next page, please? Can you please go to the next page? Yeah, go on, next page.
Yes, sir.
You haven't taken, when you say no significant family or drug history, you need to be more specific.
Okay, sir.
What is the significant family history you expect? What is the drug history you expect?
So in family history, we can expect history of malignancy since we have to rule out. We
Yeah.
have to consider the
Is
DDA
familial malignancy more on the right side of the colon or the left side of the colon?
sir, right side.
Yeah. So do you think that's the likely cause?
No, sir.
Yeah. So this again is a point that is against. What
Yes.
else would be a feature of uh, drug history? How is drug history important? What drugs are you talking about?
Um, history. Sir,
You only have put it, so you should know why you have put it. What is any medication going to cause colovesical or rectovesical fistula?
sir, actually, drug history. If the patient had some prior malignancy treatment history, that could have been mentioned.
That
Prior
is one
radiation
thing.
history,
Then what else?
prior radiation history is there, or um,
Yeah, I got that. You should have specifically mentioned no history of radiation, no history of previous malignancy,
yes,
no
sir.
history of what else? Drug history, how is it important other than malignancy? Wouldn't therapy of Crohn's disease be a possibility for
Yes,
the
sir.
drug
Yes,
history?
yes, yes, sir. No,
Yeah.
since once
Which is
occurs
why,
in the
which
trauma,
is why he has settled down from his diarrhea, or he never had diarrhea. Do you take long ago history when if there is any possible drug history? You need to take long term history of what is the course of his disease. But in this case, there is no diarrhea at any time. There is no bleeding per rectum. There is
yes,
no
sir.
prior history of inflammatory bowel disease or treatment for inflammatory bowel disease. So it
Yes,
makes inflammatory bowel disease less likely.
yes,
Accepted.
yes.
Yeah. What about addictions? How addictions or allergies matter here?
Smoking.
Please mention it specifically when you write addictions. We generally mean a longer thing. Generally, smoking addiction is not written as an addiction. It's written as a personal history, no history of smoking or allergies. How is smoking important in this?
Sir,
What is the association of smoking with inflammatory bowel disease?
so smoking is protective in Crohn's disease, but it can exacerbate ulcerative colitis.
Is it the other way around or this is the way around?
Um,
I think it's the other way around, but I'm not sure. Anyway, what else? What else is the history of smoking important for?
it can be a precursor of malignancy also because carcinogenic exposure is there.
Yeah, sure. Uh, you said previous history of surgery is not there.
Yes,
In
sir.
a male, what kind of surgery would he have undergone which would require pelvic radiotherapy?
Mm. Sir, in testicular malignancy, so it can be the
Testicular malignancy, you don't do abdominal surgery. And how is testicular malignancy important?
sorry.
He has not given any history of surgery also. You have not written. You should write that. No history of previous surgical treatment.
Okay, sir.
CA rectum.
CA rectum, yes.
CA small bowel, CA what do you call rectum, CA colon, and in females, carcinoma of the cervix. That's what you should answer. Because he's a male, it's unlikely to be carcinoma of the cervix.
Yes.
Yeah. Prostatic malignancy can also result in a recto-urethral or a recto-vaginal recto-vesical fistula.
Okay.
Yeah. So you should mention that by name. Next slide, please. Next slide.
So in general examination will be started.
Yeah, please start.
So the patient is conscious and alert, well-oriented, time, place, and person. He is moderately built and nourished with a BMI of 26. The patient is afebrile with pulse of 86 per minute with normal rhythm. The respiratory rate is 17, SpO2 is 97%, and blood pressure 120 by 70. There is no evidence of any anemia, jaundice, cyanosis, pedal edema, clubbing, and there is no palpable lymphadenopathy. On abdominal examination inspection, the abdomen is flat, the umbilicus is centrally placed. All quadrants are moving well with respiration. There are no scar marks, dilated veins, or visible peristalsis seen. No skin lesions. The hernia orifices are normal. External genitalia appears normal. The spine is normal, and the Foley's catheter is present in situ. On palpation, the abdomen is soft, non-tender. There is no palpable lump or no organomegaly. On percussion, the liver span is 11 centimeters. The perrectal examination, there is no blood staining or melena. There are no skin tags, piles, fissure, or fistula, or any other scar marks. The cardiovascular system, central nervous system, and the respiratory system, there are normal. In summary, a 45-year-old male presenting with symptoms of recurrent UTI, passage of fecal matter mixed urine, old history of constipation. So this is the summary.
Yeah. Why did you say chronic diverticulitis? Diverticulitis is never chronic.
Okay, sir.
It is acute colonic diverticulitis. It's an acute event. Similarly, you can get in Crohn's disease, you can get a colonic, you can get a perforation, limited perforation, and you can develop a pericolic or a peribowel abscess,
Yes, sir.
which then causes adhesion to the dome of the bladder and then causes fistulization. So I would be very reluctant to attribute the cause of fever with chills to diverticulitis because he clearly had turbid urine at that time itself. Yes, sir. Welcome.
Am I audible now?
You are audible, sir. So we just discussed what are the possibilities of colovesical or a rectovesical fistula. We are discussing Crohn's disease now. So the question was, why did he attribute that history of fever to diverticulitis and not to Crohn's disease with the pericolic abscess?
Sir, the fever here is due to the UTI, sir. Actually, I mentioned it in the history, sir.
Why do you think it's UTI? Just because of turbidity of urine or something else?
Sir, actually,
what would be the history if it was a colovesical fistula secondary to chronic or acute diverticulitis or a pericolic abscess?
Sir, in this case, the fever started after the patient developed a fistula. In the case of chronic abscess or acute abscesses due to the diverticulitis, the fever history could have been prior. He could have also a prior history of hospitalizations also and treatment also, sir.
Yeah, so that's why I don't agree with your diagnosis. So what is the differential?
Uh, So the three most common differentials. The first one is the chronic diverticulitis. The second is the can be malignancy or Crohn's.
Why not put Crohn's or malignancy? Crohn's also there is history against it. No history of fever and diarrhea. No history of what you call passage of blood or melinous stools. All this is against the Crohn's. It's also partially against malignancy. But you don't need absolutes like you can't say they will have bleed all the time. They'll have melena all the time. They may not have it, but Crohn's is a more prolonged history before you get this sort of symptomatology.
Yes, sir.
While malignancy can still explain it. The entire episode of disease is how many months?
Sir, the 6 months is the
Yeah, so 6 months will suggest a malignancy which is either silent and not showing any hematochezia or melena. So that's why he's not gone to the hospital. He had chronic constipation with diverticulae, and it would explain the diverticulae that are being visible. But at the stage of diverticulosis, which precedes diverticulitis, you would have also had a history of bleed because diverticulosis is most commonly presents itself as a bleed. Otherwise, it's asymptomatic except for constipation.
Yes, sir.
Yeah. So, what is the diagnosis you have come to now?
Sir, actually, sir.
With your rectal examination, what have you proven? You have done a digital rectal examination.
Yes, sir.
Does that rule out a colonic rectal fistula?
So, pardon, does that rule out a
rectovesical fistula in carcinoma by putting a finger? Have you disproved rectovesical cause?
Sir, in PRV, I could not feel a pile mass. I'm sorry, a mass, no, not a pile mass. I could not feel, I could not palpate any mass in the rectum.
So, what does it rule out?
Sir, there is no rectal involvement of the disease.
Can you palpate the entire rectum with a digital rectal examination?
Oh, sir, it's not possible.
So, upper third rectum you may not feel by doing a rectal examination.
Yes, sir.
And it's upper third rectum that's more likely to cause a rectovesical fistula.
Yes, sir.
Yeah. So malignancy seems to be more and more important. He need not have metastatic disease. He need not have other disease which is locally aggressive. But 6 months, to my mind, feels that you should include rectal or colonic malignancy with a fistula to the bladder, presenting with an acute episode of urinary tract infection or pericolic abscess with rectovesical or colovesical fistula. And even the sigmoid colonic malignancies also, you won't feel anything on digital rectal examination, but you could have a fistula.
Yes, sir.
So my personal working diagnosis would be to exclude the fistula. So what investigations would you do?
Sir.
Sorry, Ravindu,
Yes, sir.
can you hear me now?
Yes, sir. Loud and clear, sir. Please.
Okay. So sorry, we lost connection in between. Few points. One is, as Dr. Desai said, that diverticulosis and diverticulitis, these are two different entities.
Yes, sir.
Diverticular disease or diverticulosis is the underlying pathology.
Yes.
When inflammation occurs, it becomes diverticulitis.
Yes.
And it can also manifest with just rectal bleeding, fresh bleeding per rectum, painless bleeding. So these are two different entities. And as he said, diverticulitis is always acute diverticulitis. There is no entity called chronic diverticulitis, just as there is nothing like chronic appendicitis.
Okay,
now, at some point, you said that there are no bowel symptoms. That is not correct to say because he has history of constipation for 5 years. You could have said that there are no bowel symptoms to suggest inflammatory bowel disease. That would have been a correct statement because most patients with inflammatory bowel disease, and here we are talking of Crohn's disease because fistulae do not occur in ulcerative colitis. Ulcerative colitis is a mucosal disease, whereas Crohn's disease is a transmural disease. So fistulae occur either in Crohn's or in tuberculosis. And in a patient who doesn't give history of diarrhea or bleeding, yes, I agree, you would not make a clinical diagnosis of Crohn's disease. Then at some stage you said, since there is no weight loss, I will not entertain a diagnosis of malignancy. That is not correct. I have said it so many times. If the history of anorexia and weight loss is there, that supports your diagnosis of malignancy, although you have to remember it can be present in tuberculosis also.
Yes.
But if there is no history of anorexia and weight loss, it doesn't mean that it cannot be malignancy. Not all patients will have anorexia and weight loss. Also, you have to remember anorexia and weight loss is, as a group, more common in HPB malignancies as opposed to GI malignancies. Even in GI malignancies, it is more common in esophagus and stomach as opposed to colorectal. So colorectal malignancies are the least common, and of course, retroperitoneal malignancies. Then you said smoking. Now, if I remember correctly, smoking has a strong relationship with bladder cancer.
Yes, sir.
And that can be the cause rather than rectal malignancy. Bladder cancer can cause a recto or colovesical fistula if it is infiltrating. So that is the importance of smoking. Then you said no fistula and no piles on per rectal examination. You cannot detect a fistula on per rectal examination unless you feel the indurated internal opening.
Yes, sir.
Also, as Dr. Desai said, that if most of these fistulae occur to the dome of the bladder, that is much beyond the reach of your finger. So if you had said per rectal examination, and similarly, you cannot detect piles on per rectal examination. Piles are seen on proctoscopy.
Yeah.
But you didn't say proctoscopy, you only said per rectal examination. Generally, per rectal examination is presumed to be only digital rectal examination. So you should have specifically said proctoscopy. And in a patient who has a colo or rectovesical fistula, your clinical examination is incomplete unless you do a proctoscopic examination. You have to at least mention, even if you don't do it in the exam, you have to say that I would like to do a proctoscopic examination. That would at least see something in the lower part of the rectum, whatever is seen. So here, diagnosis of colo or rectovesical fistula, and you cannot say that it is colovesical. It could still be rectovesical beyond the reach of your finger. So it is a colo or rectovesical fistula. And because you cannot make a clinical diagnosis of the cause, you should have discussed the possible causes, which as one by one you mentioned, but in one go you should have mentioned that the common causes of a colo or rectovesical fistula are diverticular disease complicated by diverticulitis, Crohn's disease, malignancy, trauma. Trauma is an important cause, especially in women, obstetric trauma, and radiation injury or surgical trauma. So all these things you should have discussed. And here, because there is no history of diarrhea and bleeding, yes, it is difficult to make a diagnosis of IBD or Crohn's disease because, and you should have clearly said that there is no episode of severe left-sided lower acute abdominal pain associated with fever, which would indicate an episode of acute diverticulitis. So that negative history should have come from your side. It is difficult to say that this is a fistula because of diverticulitis, but you cannot rule it out. As we discussed, majority of patients with Crohn's disease have diarrhea and bleeding, but some patients may not have diarrhea, may not have bleeding. So you have to, as I say, that in some cases you cannot make a diagnosis, but you have to discuss the pros and cons of each differential diagnosis. Now, if we ignore that 5-year history of constipation, suppose that is totally unrelated, 6 months history of UTI and symptoms suggestive of colo or rectovesical fistula, you have to keep malignancy in mind. This could be the only manifestation of malignancy, and the growth is above the reach of your finger. So you can't exclude malignancy here. All these possibilities still remain. Okay? That is how a case where diagnosis is not obvious needs to be discussed at MCH level. Yes. Please proceed. What will you do? This patient comes to you in the OPD. Rajendra, anything else on history or examination?
No, sir. Perfect, sir.
Okay. Yes, Navendu. Davendu?
Should I proceed, sir?
I think he's not there. Yeah. What will you do? This patient comes to you in the OPD.
Pardon, actually the connection was lost. Can you please repeat the question, please?
Sorry, please repeat again. I could not hear you.
Sir, the connection was lost. I was also not able to hear you.
Okay.
Please.
So this patient comes to you in the OPD. What will you do?
So first of all, we should do a urine routine examination simply, and we can.
In a patient who gives you a frank history of fecaluria, you think routine examination is going to be normal?
No, sir, it will not be.
Very unlikely. I'm not saying you will not do it, but it's not going to help you.
Okay, sir. Sir, since the colovesical fistula, the diagnosis, actually, so since the patient has come in the OPD, if he is not septic, generally the patient can be septic with recurrent UTI and all that, we can progress to the radiological. Hello?
Lot of echo coming from Kapoor's side. Maybe two systems are on to the same this thing, so they will be echoing between each other. So ask people who have other systems logged onto this to shut off their microphone button. Yeah, Navindu, let us go ahead. It's already 9:36. Let's go on.
Yes, sir. Since the patient has come in the OPD, if he is stable, since the patient are recurrent UTI, they can be highly septic. If the patient is not septic, we can progress with the radiological investigations. Because
what are they?
Sir, since we can do simple cystourethrogram to see the communication between the.
How often do you do that? The urine is turbid. There is frank fecal matter, so there is no doubt to see an opening.
Yes, sir.
How will it help you make a diagnosis that will help? Only bladder tumor you want to rule out.
Yes, sir.
Okay, but will you be able to distend the bladder if there is a large fistula?
No, sir. No, it will not.
So you won't be able to do a cystoscopic examination.
No, sir.
Yeah. So what test would you like to do that would help you? Would you like to do a barium enema or a cystourethrogram?
Sir, barium enema can also be done. However, the investigation of choice in the case of colovesical fistula has been mentioned as CECT with oral and rectal contrast without IV contrast.
Yeah, accepted. Yeah, accepted. That can be done as a one go.
Yes,
but
sir.
this was the imaging we used to do. We used to do a contrast enema rather than a cystourethrogram. Because the pressure in the colon is higher, flow into the colon may not be there if the fistula is small. That's all I wanted to highlight.
Yes, sir.
And you have a frank fistula here, which you want to tell whether it's because of malignancy. A contrast enema also will show evidence of malignancy. This has been replaced by CECT now because it's a more advanced investigation. It gives you more information on the anatomy of the fistula. It rules out the diseases that cause the fistula or may point out toward the disease causing the fistula, all three in the same setting. If the patient is in sepsis, the first step you should be doing is starting him on evaluation and starting him on antibiotics, and then concentrate on finding source control.
Yes, sir.
Yeah, as you said, that's perfectly fine. So, what did you do next, imaging wise?
Since imaging CECT has been done, should I discuss the CT or should I go next? First, what we'll do?
Go according to the sequence as given to you.
Okay, sir. So after CT, in the CT we can.
No, you show us the CT.
Okay, sir. So this is the CT of the patient. Actually, the investigations of the patient were done outside. They were not done in our hospital.
I saw a barium
Yes, sir.
enema by the looks of things. Yeah.
Yes, sir.
What does this show?
So it was a normal study, as you stated, because
You don't-
yes, sir.
Yeah. Next.
Sir, in the CT, we can see there's air in the bladder.
Okay.
Since there is no history of any previous instrumentation surgery, so this is an indicator there is a patent fistula is present, sir.
Okay.
And in these cuts, we can see, sir, the large bowel is in close contact with the with the urinary bladder, sir.
Okay. What does the large bowel show? Is there any feeling of diverticulia? Is there any evidence of diverticulosis or diverticulitis?
Sir, act- so actually, I was not able to make out it very well.
Okay, at least these films are too small for me to be able to make any kind of diagnosis actually. Could you show us the report, please?
Yes, sir. This circumferential symmetrical thickening without any luminal narrowing of the sigmoid colon with multiple small diverticuli, wall thickness up to 8 mm. Approximately 25 mm long and 20 mm thick fistulous tract is present between this segment and the superior wall of the urinary bladder. The orifice is about 3 to 5 mm.
Okay.
The adjacent urinary wall appears mildly thickened up to 4 mm and air foci is noted in the urinary bladder lumen.
So now what is your possibilities that you have to put in?
Sir, the fistula is from the sigmoid colon into the urinary bladder, sir. And
Okay.
there's no, since there's symmetrical thickening, there's no mass lesion seen in the colonic wall.
Yeah, so what Asian disease can explain this kind of finding? That's a big hint I have given you actually. Could it be that? Not able to hear you. Can any benign cause be there with a smooth symmetrical thickening which is not causing luminal narrowing, which can result in a fistula?
Asian disease,
Tuberculosis? Yeah. Tuberculosis you should always think of. Tuberculosis is the cause of many diseases in the colon. But it is an uncommon presentation if it is tuberculosis. But when a common disease is there, an uncommon presentation still means a sufficient patient load to make this diagnosis a possibility. So you should definitely consider that as a possibility. So keep it in the second place. So if there is symmetrical narrowing, does it actually rule out all kinds of malignancy? Can we not have still a symmetrical
we can
thickening?
have, sir. We can have.
Can, but it comes to lower priority. So we come with diverticulosis with no evidence of diverticulitis, but thickening of the wall of the colon could be an early formation of a diverticular stenosis. It could be tuberculosis. So that's where we are. Malignancy seems less likely based on this fact. Okay, go on.
So after the CCT, since we have to rule out malignancy, definitely we can do a sigmoidoscopy or a colonoscopy
Okay.
to see the local, if any local lesions or as such are present.
Yeah, sure. Show that.
Sir, the sigmoidoscopy was done outside. We only have a report.
Okay, go on.
So in the sigmoidoscopy was done, which was seen up to 40 centimeter from the anal verge. It reported a normal mucosal and vascular pattern throughout.
Okay.
Two fistulous openings are seen at 30 centimeter from the anal verge, and beyond 40 centimeter, there was stool, so they did not progress.
So what is your possibility now? It makes tuberculosis seem more likely.
Yes, it can be a second possibility. Yes, sir.
Yeah. Next.
So after that, so these are the basics they were done, sir.
Okay, so what would you like to do?
Sir, in the present case,
Did they do any biopsy in the sigmoidoscopy?
We can do a biopsy if any lesion or any as such is present. We can do a biopsy to rule out the malignancy because the
Yeah. Would you like to do a colonic preparation and try to do a uh, colonoscopy and see what's happening?
Sir,
Because we still haven't ruled out inflammatory bowel disease, except that there is no diarrhea.
yes, sir.
And yeah, that's the only thing against it, and no history of previous episodes of diarrhea with abdominal pain we don't have. That's the major thing against Crohn's.
Yes, sir.
But you put it at the bottom of the list, possibility of inflammatory bowel disease.
Yes. Yes, sir. So we,
What about suggestion of appendicitis with pelvic abscess?
sir, sir, the patient never had any complaints of right iliac region pain, sir. Right iliac fossa pain.
Umbilical pain also he didn't have.
And
Okay,
umbilical
let's
pain,
go on.
yes.
Yeah, let's go on.
So there are no such suggestive history also.
Okay. So do we have any kind of proof now as to what is the final diagnosis?
Sir, since in the CECT the diverticuli are visible, there is
Yeah.
no masked lesion, and this is the most common present. The colovesical fistula, the most common cause is due to complication of the diverticulitis.
But
So,
like we said, there is no abscess seen in the pericolic region.
yes, sir, there is no abscesses seen. Yes, sir.
So that might have come down because it's ruptured into the bladder. That's one possibility.
Yes, sir.
But still, significant diverticulitis will cause some amount of stricturing of the colon. That being absent in this case is also a fact against that diagnosis.
Okay, sir.
And multiple fistulous openings are seen. These are seen in Crohn's and tuberculosis.
Yes, sir.
So I would like to take a biopsy and send it for RT-PCR, histopathology, and get a further imaging done, get a complete colonoscopy done. That would be my approach. Do a complete colonoscopy, do multiple biopsies, see if there's any lesion to suggest malignancy like other polyps or anything in the colon. So I would definitely do a colonoscopy. I'm not satisfied with what was done outside. They could not see beyond 40 centimeters and it's full of stools. So
Yes, sir.
40 centimeters means where in the bowel they're in mid sigmoid.
Yes, sir.
Yeah. So, and they've already seen the fistula,
Yes, sir. They have seen the fistula.
but they have not seen any evidence to suggest Crohn's disease. No cobblestoning. What
No,
are the
sir.
other features of Crohn's disease on colonoscopy?
So skip lesions, cobblestoning is the most common feature, and the rectum is involved. Sorry.
Rectum is involved.
No, sorry. Rectum is always paired. I'm sorry. Rectum is always paired in Crohn's.
Not always paired. Sometimes paired. One of the commonest causes for multiple fistula in ano is Crohn's disease.
Okay, sir.
Yeah, so it doesn't rule out that disease
Okay, sir.
just because there's no rectal finding. But in ulcerative colitis, in the absence of rectal involvement, the possibility of it being ulcerative colitis is less.
Yes, sir.
That statement you can make.
Because it's not a fistulizing disease.
Yeah, Dr. Kapoor, are you there? Hello? No, I can't see Professor Kapoor. So what else? So no biopsy reports are still available? Patient
No,
is
sir.
with you?
Yes, sir. The patient has been actually the operated also. Sir.
Yeah, so what was found? So your diagnosis was acute diverticulitis with colovesical fistula.
Diverticulitis with colovesical. Yes, sir.
So how much of bowel did you remove?
Sir, we have to ensure to remove the sigmoid up to the up to the rectum junction, sir. We have to remove the index up to at least up to the rectum. Because
Okay.
we do not, we do
What
not
was
want to
the
influence-
histopathology of that specimen?
Sir, the specimen report is still awaited, sir. It takes
Okay.
5 to 7 days.
Please update us of the report. Still a lot of possibilities are there.
Okay, sir.
Yeah. Anything else you want to know?
Hello,
Yes, sir.
Yes, sir.
am I audible now?
Now you're audible, sir. No echo either.
Yeah, I think based on the endoscopy, because mucosa is normal, vascular pattern is normal. If the diseased area has been seen, because obviously they have seen the fistulous openings at 30 centimeter and they have seen up to 40. So that means they have seen 10 centimeter beyond the I think up to बंदा तैयार है, we can start using that.
Yeah, now we are audible, sir. Navendu, are you there?
Okay. So yeah, Navindu. So what I was saying, that since endoscopy shows normal mucosa and normal vascular pattern, inflammatory bowel disease and tuberculosis are less likely because these are both mucosal diseases. So there should be some mucosal ulceration, some change in the vascular pattern. So with a normal mucosa and normal vascular pattern, I would put diverticular disease with an episode of acute diverticulitis, which is not reported, which is not noticed by the patient, and that has caused the colovesical fistula. That would be what my diagnosis would be. Yeah. So Dr. Desai was asking you about the treatment, and you said you would go ahead for resection. He was asking you what will be the extent of colonic resection and what exactly will be the procedure. Can you tell us what will be the procedure?
So we have to do resection of
I think
Not
Navendu's
able to
connection
hear you,
also is
Navendu.
weak.
Sir, am I audible now?
Yes.
Yes.
Sir, in this case, we have to resect the involved bowel segment. It will, since it is sigmoid, we'll plan an anti-resection, sir. Up to the rectum, we have to ensure that the bowel up to the rectum has to be removed so as to prevent any future recurrences of the diverticular disease.
So you will do only bowel resection?
With the repair of the bladder, or if the segment of the bladder which is involved, it can be removed also, and the primary repair can be done, leaving the Foley's catheter in situ for allowing the bladder to heal. This can be done as a
depending on the site and extent of involvement of the urinary bladder, if it is in the dome of the bladder, which is the usual site for a sigmoid diverticular disease to involve, you may have to remove a part of the dome of the urinary bladder, repair the bladder, and drain the bladder.
Yes, sir.
So what would you like to do on the table with the bladder to ensure you are dissecting it properly?
So we will understand if you are doing an open surgery, so we have to actually know the exact site of the fistula. So we catheterize and we can put some dye in the bladder to remove the involved fistulous tract segment.
That's not correct, because when you put in dye into the bladder, it stain the entire bladder, whatever stain you're planning to do. So that doesn't make sense. But you need to fill the bladder, because when it's a collapsed bladder, the area of involvement will be seeming to be more than actually what it is.
Okay, sir.
And also by distending the bladder, you know the capacity of the bladder.
Got it. Okay, sir.
Capacity of the bladder is important in diagnoses like tuberculosis and Crohn's,
Okay,
where
sir.
the volume of the bladder will reduce due to fibrosis.
Okay, sir.
Yeah.
So
So
where
did you
exactly
distend it
would
on
you
the table?
divide bowel distally?
Sir,
What will be your
just
distal point of division?
sir, the junctions, the upper rectum and the sigma junction, we have to divide the at least
Since most
In
likely this is
centimeters,
a
how much?
benign disease,
uh, centimeters. Sir, sir, yeah, we have to do anterior resection, sir. So the upper rectum, we
If the cause is benign, why do you want to remove the entire part? You
no,
want to
no.
eliminate diverticulitis? That doesn't necessarily happen.
Okay, sir.
see your plan is to remove the sigmoid, so you divide it at the rectosigmoid so that you have a safe intraperitoneal anastomosis. There is no need to divide even the upper rectum. You divide it
Okay,
at the rectosigmoid.
into sigma.
In fact, depending on the operative findings, you can even preserve some part of the distal loop of the sigmoid or the proximal loop of sigmoid, because that will give you extra length. If you are doing a full sigmoidectomy, then in order to do a tension-free anastomosis, you have to mention that you will mobilize the left colon. You may
The
even have
splenic
to
flexure
mobilize
is
the splenic
mobilized.
flexure.
Yes, sir.
So all
Yes,
these
sir.
things have to be mentioned. See, at the MS level, it is good enough if you say what procedure will you do. But at this level, we want to know from you what are the
Yes,
important small steps of the procedure.
yes,
So
sir.
if you want to do a descending colon to rectum anastomosis, it may not be possible without tension unless you mobilize the left colon. In some cases, as I said, you may even have to mobilize the splenic flexure.
Yes, sir.
But the resection is conservative because you are dealing with a benign disease. You only
Yes.
remove the diseased part. Of course, and the other is that you need not take the mesentery. You can stay as close to the bowel as possible, because the aim is to only remove the
Yes.
bowel, not the mesentery or the areolar tissue or the lymph nodes. If there is a doubt of malignancy, then obviously you will treat it as malignancy. Then the extent of resection will be different. But if there is no doubt of malignancy, then it will be because for all these diseases, whether it is diverticular disease, whether it is Crohn's disease, or whether it is tuberculosis, the resection is conservative. You only need clear, gross, clear margins, healthy margins, and a tension-free anastomosis.
Yes.
But you have to mention that some part of the bladder may have to be removed. How do you repair the bladder? How do you drain the bladder? How long do you drain the bladder? When do you remove the Foley's catheter? All these things will come as counter questions. How do you
Also,
repair
what
the
is the
bladder?
capacity of the bladder? Also, the capacity of the bladder is
Yes.
important to assess. If it's only the dome, it's okay, but you're saying multiple fistula at 30 centimeters. So a significant portion of the bladder may be involved. And if you think this is diverticulitis, you need not excise the bladder wall at all. People dissect between the plane of the fistula and the bladder without trying to look for it. Do a filling test of the bladder afterwards with a dye. And if there's any leakage, repair that. Only in the situation if it's tuberculosis or malignancy, you won't do that.
Can we see the CT scan again? Do we see retrospectively what the radiologists have reported? We missed that. Can you please go back to the CT, the axial cuts?
So actually, the CT scan is from outside. I was only
Yeah, but
able
if you
to.
see the axial cuts, the middle row and the first cut,
One.
can you enlarge on that? Middle row and the first cut, axial.
First cut. Okay.
Yes, this one, this one. So here,
Sir,
because
one
in the
minute.
very next cut, you see the bladder.
Let me. So is it visible?
Yes. So in the second cut of the middle row, you can see the bladder,
Yes,
and
sir.
you see some air inside it
Yes, sir.
at the top.
Yes, sir.
And in the previous cut, the first cut in the middle row, you can see that a loop of bowel is coming very close to the bladder,
Yes, sir. It's coming close.
this area.
Yes, sir.
So I can't appreciate whether there is some thickening, what they have reported. But keeping in mind the possibility of a colovesical fistula, this doesn't look normal.
Yes.
And that also helps to tell you that it is the dome of the bladder. Did we discuss cystoscopy? I missed in between whether a cystoscopy was
We
done or
discussed
not.
that. We thought because of the rectovesical fistula, distending the bladder to its completeness might not be possible. The only role would be if it was suspected to be a bladder malignancy infiltrating the colon as a possible cause. In those cases, we would do a cystoscopy.
No, I was thinking whether it would help us to plan the procedure by telling us which part of the bladder, as you said, whether it is the dome or the trigonal area. Because if it is dome, then it is easier to manage. If it is trigonal area, then you have to take a lot of other precautions. You may have to cannulate the ureters and all those things. Also, depending on the location of the fistula, you will have to see whether there is any possibility of the process being very close to the ureter, and whether in order to protect the ureter, because this is an inflammatory process, there will be a lot of inflammatory fibrosis around the tissues. So whether in order to protect the ureter, you need to cannulate the left ureter perioperatively.
Yes, sir. But also the other problem was this patient has frank fecal urea. So any cystoscopy which distends the bladder could precipitate a septic episode. That's another reason I think we would be conservative about cystoscopy.
Okay. Yeah, but a good CT scan should show you
Yes,
what
sir.
is the likely site of involvement of the urinary bladder.
We are not able to see the films because they're so small. Even with enlargement, we try to see what is the largest size we can get to, but selected cuts have been put. Sequential cuts have not been given. I think there's only 1 or 2 films that have been given.
So has this patient been operated?
Yes, sir. It has been operated, sir.
What were the findings? Can you tell us?
Sir, the sigmoid colon was actually the fistula was between the dome on the towards the left side and within the sigmoid colons. And when the opening of they were separated, the two openings were not seen. There was one large opening was there, sir.
And the final biopsy?
So the biopsy is still awaited, sir.
Okay. Okay. Thank you. Thank you, Navendu. Thank you, Rajan.
Thank you, sir.
Thank you, sir.
Shall we close?
I think we can.
Okay.
Okay, sir. Bye.
Thank you, sir.